Dr. Galiatsatos, take it away.
All right, thank you, Susan. Thank you guys so much. An honor to be here. And also, full disclosure, our initiative, Medicine for the Greater Good, puts on an annual symposium. This year is going to be November 16th. It's virtual as well. We'll make sure, Laura and Susan, you have the information to distribute. The theme, there's always a theme. Last year, we celebrated the 30th anniversary of the Americans with Disability Act with our speaker, Jessica Long. Lena Wen was one of our first speakers to kick things off when she was our health commissioner. This year is the New York Times bestselling author D. Watkins, and he's going to make an emphasis of how we should invest in our youth. So it should be pretty phenomenal. And there's a great panel discussion afterwards. So when I've been invited now multiple times to give talks on health equity, I've actually taken a step back that I want to pursue. Let me put it this way, health equity, there's a lot of conversations. There's like, oh, disproportionate populations are being impacted. And I see this because I think for a lot of people, you start feeling like, well, what can I do? Right? You hear this over and over and over again, you know, life expectancy differences, et cetera. What can I do? What can I do? And actually, that's what I'm going to give you guys an insight into today, into how to be strategic with what can you do. So the initiative that I oversee, Medicine for the Greater Good, we do that. We train physicians to, you know, they'll know the science, they'll know the patients, and we teach them how to know the community and how to implement community engagement that is utilizing somewhat of sophisticated science in order to make the biggest impact. Some of our first things you can do with community engagement is really dissemination of information. And you saw that no more truer than during the pandemic, right? Because in order to make sure that our hospitals weren't overfilled with patients, you had to make sure the community understood how to not catch the virus. And you had to engage with them, not only just share information, but make it culturally relevant, make it part of their identity, make it so they feel like, yeah, I want to do this. I mean, you guys have all tried to persuade a human being some point in time in your life, whether it was your children or grandchildren. You know, persuasion is hard. You can't just say, do this. You have to kind of find something that interests them to do just that, right? And so what we're going to go over for the next, 30 or so plus minutes, and I'll gladly take Q&A, is I'm going to go over that specifically, right? In order to mitigate healthcare disparities, there's a variety of things we can do. But one of the first things we should emphasize is community engagement. Because if you could do that strategically, then you kind of have an understanding of what the community is experiencing, what it's going through, and you can be much more strategic in how to advocate for them. So let me go ahead and share my slides. And oh, someone's got to let me have permission to do just that. Otherwise, I'm happy to just talk, which is completely fine, but you'll miss out on my fun visuals.
Dr. Galiatsatos, give me just a second.
Take your time, take your time. And as we're waiting for permission on my end, which is fine. If it's not granted, happy to just have this as a conversation.
No, you're good.
Oh, I'm good? All right, no worries. All right, and Laura, can you just give me a thumbs up that you can see my slides? Perfect. So yeah, so population health and community equity strategies, and health equity strategies, sorry, community engagement. I have no disclosures. These are the three objectives, whether they're there, and you guys can all have my slides, Laura. I'll make sure I email them to you later. But to understand the differences when we say about community health versus population health, this is more often said in the hospitals, right? We think of population health strategies. So I'm going to try to differentiate the two and to understand the principles of social networks. I mean, this is important, right? You all may think of yourselves as your own community. Well, what identifies you? What defines you is important, because when you want to do community engagement, the first key strategy is a dissemination of just information that you're hoping aligns with their purpose, their identity, their own will, and so forth. And then we'll go over a few examples as well. So let's move forward. Oh, sorry, I'll try to speak much louder. Sorry, that's usually not an issue sometimes. So these microphones are always a little different. All right, so let's dive into this. So what is community health, right? And when you think about it, I mean, the community health at its core is something that the community should define. Right? What does health mean to them? Right? This is a beginnings of the key insight for many physicians when they suddenly realize health and medicine are not synonymous. They are very different. For the community, health may be, hey, we have jobs. Hey, we have food on the table. Hey, we have, a collection of A, B, and C that defines us. Community health, really to some extent, is this notion of well-being. And this is key because sometimes in medicine, we always say, hey, if you lack a disease, that's great. But for the community, as they define things, a lack of disease doesn't necessarily mean health. As I said earlier, health to them is sometimes just defined by social outcomes, having a job, for instance, having an identity, and so forth. So community health is one that's shared by a collection of individuals or organizations, and oftentimes they're defined either geographically or culturally. And culturally can be things like a faith-based organization, a nonprofit, etc. But this is key, right? Because this is something that is defined by those individuals. Versus population health, this is something that hospitals constantly think of. Every hospital discusses this, right? But they use very different endpoints. They discuss the prevalence of diabetes or the prevalence of COVID. And then they work kind of backwards. Well, how do we mitigate that, right? In order to make care more cost effective, to take off a little bit of the burden, and not use in an inefficient way hospital resources. This is what we sit in with meetings and constantly talk about. But they're not the same, right? This is key because anytime a hospital thinks of population health, and I've gone to many hospitals and given these talks, and if they don't have a community health arm, I'm letting them know you're setting yourselves up for failure. The analogy here that I often say is it's like thinking of a disease plan, but never having a doctor or nurse implement it, right? I mean, you got to have both strategies, but you also have to recognize there are differences here. So community health, at its core, it's meant to be collaborative. It's meant to be empowering to a community. And how you define the community, it could be culturally, it could be geographic. Oftentimes, and we'll go over this, right? Because you'll see where this direction is going, right? But the most, sometimes the biggest bang for your buck tends to come from certain communities versus others. So we'll go over that in a second. And then what is the measurement for community health? And for their standpoint, it's their overall health. And again, what is that? It's defined by them. That's key. You have to make sure health is always being defined by that entity. Population health, a little bit different, right? There's outcomes, there's accountability here, there's defined attribution, there's interventions at play about access and prevention. That's what they're focused on. But if you begin to recognize population health is really more population medicine, it is focused on diseases rather than promotion of health. That's key here, right? Because what we end up doing is finding a surrogate or finding a disease outcome and work backwards versus community health, which is a lot more perspective and forward thinking. And not to say they're both needed, right, in order to kind of gauge what's going on, but it's so important to recognize that they are different. All right, perfect. Sorry, took a pause to see about that background noise. Okay, now there is some overlap though, because when they are overlapped, this is where you can, we talked about health equity. If you want to mitigate healthcare disparities, you have to think in this sense. Community health and population health, they have to come together. Disease prevention coupled with health promotion, right? So disease prevention is your population health, health promotion is your community health. They have to come together. You have to work with a defined area, of course, whether it's geographic or culturally grouped one. And then you need what's called a health needs assessment. And what the purpose of this, so the Affordable Care Act, for instance, actually, to some extent, was the genesis of requiring all hospitals to do this. Go around to your communities, discuss what health means. Now, the challenge here, though, is sometimes when the hospitals define them, they use population health endpoints, right? And so I've seen this out of Hopkins, out of University of Maryland, of how they put these out. I'm like, I wouldn't phrase it like that, because those are interests more of the hospital, not of the community. Other great ways of doing health needs assessments we've done when you go out and just let the community speak to you. Actually, we've partnered with a lot of individuals from our art institution here at Hopkins, from Peabody and others, and just used the arts to be a way for people to identify and discuss their health through storytelling or music or poetry, right? What I'm alluding to is health is a human construct. So let humans discuss it in a humane way, right? Let the humanity sometimes speak to it.
Message playback. No.
Medicine in of itself, right? That's the population health strategy. And there's a disconnect there, but one that we can overcome with just these community engagement efforts. So I'm building all this up because now you're sitting here, you're like, all right, where are we going, Dr. G? How do we put this all together? Well, we put this all together for a bigger outcome, right? And that big outcome, it's public health. And public health, I can tell you, it becomes effective when you align community health and population health. And if everyone's on the same page, then you can create advocacy, and suddenly you can put this moment in time into a permanent movement. That's the purpose of public health. And the best public health strategies have always come about when community health and population health have come together. Great. So if you want to mitigate healthcare disparities, this is key. You've got to have public health outcomes. With that said, let's scale it back a little bit and go back to community engagement. Because from my standpoint, anyone sitting here saying, well, what role can I play? Community engagement is a role we can all play. But there's got to be a strategy to it, right? This is key, right? When I give these lectures, I start getting interrupted and people are like, well, we're doing a health fair. Like that's not, health fairs aren't social networking. Health fairs are not community engagement as requested by the community, right? And I love this because there was a poll out of Hopkins and says, I have plenty of free pens on their kind of free response. We don't need health fairs, right? And that's key to recognize, is it's something the community's requested. So let's take a step back and discuss how to engage with the community in a strategic way to disseminate this information. And I'm going to go over 3 principles here of community engagement. And recognizing that is key to how you step back and say, well, how do we then go and disseminate this information? This isn't a lecture on how do I do good public speaking. This isn't going to be a lecture on, how do I approach them in a grassroots fashion. This is going to be an insight into why some communities are much more impactful than others. And when you recognize that, it doesn't mean the other communities are bad. It just means, well, you have to reinvent your messaging and how that's adapted. That's key. So let's go over 3 principles to social networking, to the success of public health information to be disseminated. And if you can achieve that, then suddenly you get the community's health interest, and suddenly you can align it with a population health strategy, and then you can make a public health outcome. So these are the types of social networks we've worked with, and we'll go over all of their pros and cons, from schools to faith-based organizations, housing units, neighborhoods, and other nonprofits. Disseminating information there, and for some, is more effective than others, but it always has to, you have to have an understanding of how are they organized, and we'll go over that. The first key principle about disseminating information takes advantage of a variable called transitivity. So you may sit back and say, well, what's transitivity? Right? Here's the Webster definition. Of course, it's a relation between elements that if the relationship holds between 1 and 2, it's going to hold for second and third. In the simplest terms, it's, hey, I shared this with my cousin shared it with her friend shared it with Bob shared it with Ross, and so on and so on. It's literally just passing information around, right? Here's a great model for it of kind of how the relationships are built. And if they hold true, that information will continue disseminating. From a visual perspective, this is it. It's just a flow of information. Transitivity is, at the end of the day, it's got other names of, well, it could be seen as gossip. It could just be seen as just sharing information. But it's literally how most people take on information and begin to have a sense of, all right, maybe it came from someone else who, I can identify with, I'm going to take it on. But this is, at the end of the day, how we spread information. Now, transitivity in of itself, that's the ultimate goal, but there's ways to make it more powerful, to make sure that information really does spread. So transitivity is at the heart of community engagement, because I want to share information that I'm hoping more people continue to share and share and share and share. in an exponential fashion, we're making the biggest impact possible. Transitivity is alive in all of these. Schools, right? You know, and when I say schools, it's not just the principals, the teachers, the students, but the networks within the schools, right? Teachers to teachers, students to students, principal to principal. That's the transitivity that's alive and well there. Faith-based organizations as well, when you get together, last week we were at Yom Kippur, breaking fast. And I imagine when we were all exhausted, we all just shared information at that moment, right? This is, at the heart of it, you can have transitivity in all of these networks. So you may be saying, all right, Dr. G, you got my attention, spreading information, we get it. How do you make it more effective? Great question. To make transitivity, assure that it lasts, right? You drop a pebble into the water and you get those ripples running. You know, if the bigger the rock, the larger those ripples are, and you want your messaging to really ripple through. To gain that level of strength in that rock, that principle has to be based on what's called homophily. Homophily is the key strategy we teach every physician before they go out into the community. You have to be seen as one of them, right? You have to be seen as the individual. You may be a Christian going into a mosque, so you got to find some common ground to make that homophily, to make that connection. One of the first key things that I tend to do oftentimes, for instance, is just share who I am, right? Because sometimes just, even if I have my own personal narrative is very different, the story still resonates as a human, right? And that human connection to a very different audience, culturally, ethnically, racially, may still be one of acceptance, right? There's a bridge there that we can overcome with just simple human conversations. So one of the first key principles we teach in community engagement is homophily, right? Because your messaging will be more well received if the community perceives you as one of their own. So what is homophily? It's the tendency of individuals to associate and bond with others who are similar, right? This is why certain groups that we just mentioned earlier, you can begin to recognize that there's a stronger homophily in some versus others. This is important, right? Again, because for that messaging to relay, it's going to need this principle. For instance, if I tell Miss Laura a piece of information and she's out at Towson Mall, I doubt she's going to grab a stranger and say, hey, let me share this with you. You won't do that. But Laura, if you are at a board meeting with your colleagues that you've known forever, you're going to share that information, right? There's a sense of like, hey, I see myself as one of them, right? If you think about it, this isn't kind of even if they were strangers, if they're at work and you guys are at the same meeting, you're going to have some introductions and then begin to share information, right? There is a construct of community that allows for transitivity to occur if there's an established homophily there. That's key. So again, how does it look on a mathematical model for those of you who just enjoy math as much as I do? But this is the principle here, right? Where the relationships between I and J and I and H and J and H are just as strong as other relationships, right? Essentially, the summation of all of this is close to one. That's key, right? And going back to this model, here it is. In the simplest of relationships, it's a symmetric one where everyone kind of identifies with one another. And that flow of information, look at it, right? That flow of information, there's a disconnect. There's a purpose why those arrows aren't attached. Homophily creates that attachment where that information just flows seamlessly through that community. If you think about it, take a step back. Diseases in of themselves, if you want to use that as a surrogate outcome, the majority of diseases in modern medicine don't happen in isolation. They happen in clusters, right? There's high prevalences of COVID in this community, high prevalence of diabetes in this community. And what we try to always emphasize when we work back from that kind of population health strategy is there's got to be something that's unifying all of that, that dictates behaviors and so forth, et cetera. Nonetheless, so when you think about that, that's where you always look at the homophily. This is, from my standpoint, when we talk about from a patient care physician driven perspective, know the patient. Yeah, this is knowing the community. What makes them tick? What's their identity, right? What drives them? Because the more you understand those community health identities, the more you can align a potential population health strategy for them to ultimately mitigate healthcare disparities. So look at these examples again. Schools are tough, right? Because you may have an identity, like I went to Calvert Hall in Towson, I'm a Cardinal. But I never felt one and the same with my teachers. I never felt one and the same with the principal and the administration. Yeah, you share the same school, but I felt more one and the same with my peers, right? The other juniors and seniors and sophomores, right? So schools are interesting because there is a sense of hierarchy, which we'll get to in a second. Then there's faith-based organizations, right? Where your own religious ties or your cultural ties establish that homophily for you, right? If I walk into the church that I've gone to since a kid and I see someone else coming in, that person doesn't really have to do much for me to earn their trust, right? Because right off the bat, I'm using a surrogate of they're here, they're having a worship service with us. I'm gonna, there's something there that's gonna unite us right off the bat, some unspoken truth that's gonna build that homophily. But other ones may be tougher. Housing units, for instance, right? You may live in the geographic same place, you may show up to the same HOA meetings, but how much do you bond with an individual in 4B versus that in 3C? So this is important, right? Because when I talk about community engagement and people want to invest in like, oh, we're going to go to the housing units and do this, you got to recognize the first principle of community engagement of just social networking and disseminating of information. There's going to be certain communities that are going to be more impactful than others. And so sometimes the information just may not resonate just because it lacks the ability to really get things started. Finally, the last principle, the hierarchies. And what I'm alluding to here is more formal, not like Regina May from Mean Girls, if that's a pop culture reference you guys all know, right, where there's informal cliques and so forth. We're going to talk about the formal ones, where there's an established understanding of the characters at play and who's doing what. So this is where, and again, the definitions right there, networks in which individuals can be classified through a relation of precedence. So here, again, go back to the math model. The reason why this, the denominator is so powerful is because there's someone or some individuals that carry more weight than others. This isn't an equal distribution of relationships. Some have more significance than others. They carry more weight. And again, it's formal, meaning those people were put there, right, in some fashion. And another way of thinking of this is this: person A holds a lot of power, and they'll disseminate that information to others who have a sense of homophily, and that transitivity is occurring. So with these informal kind of discussions, you can think of this more formally, such as churches. You get a rabbi or a cantor that discusses kind of a good, important public health service or meeting. It's going to resonate to the community and be disseminated easier. Schools, maybe, right? If the principal holds a value and he or she shares it and, hey, this is, cystic fibrosis awareness month, let's combat it. Hopefully it resonates with enough of the school that people will be in line with, right? So I see this because hierarchy, the formal one, it's important to recognize if you're well organized, but in of itself still is going to have an intrinsic property of how well perceived that formal organization is. Because the other one, the one that I'm always the least one, is always housing units. Because oftentimes a housing unit leader is not one where it's really perceived well as a leader by the rest of the community there. And I've experienced this countless times where I have a really motivated individual, he or she just can't get other people motivated in a housing unit. And it's not their fault, right? It's just living in the same geographic area for a lot of people is not enough of an identity to really make me feel like we have an established homophily or a significant one. Nonprofits, however, tends to be a good one, right? Because you usually have a formal organization there with formal roles and so forth of a hierarchy. So you can always partner with them, disseminating information and so forth. The challenge sometimes with nonprofits is they may have an agenda that you that's spelled out that you have to align with. Others are more flexible, more malleable, right? For the most part, working with faith-based organizations or schools to some extent, their identity is not one that keeps them from kind of being malleable to other concerns at that time, right? If you work with a nonprofit who's only worried about clean water in the Chesapeake and you have the COVID pandemic, it might be kind of hard to kind of get them, they'll understand it, but hard to kind of bend their nonprofit towards your will. But working with schools and faith-based organizations, again, the adaptability is present there. So that's another key variable, but I don't want to overwhelm you guys. So we'll stick with these three. So I say this because this is how I approach every community engagement that I work with. And I say this because we tend to work with everyone. We're happy to, because at the same time, you also don't want to sour any relationships, recognizing that people who work at a school may also be at a church, may also be at the same housing unit, and you recognize there's a dynamics in the relationships people have. They're not static. Like, I only identify as a Jewish person who lives at Roland Park. There's other complexities to that, right? And so you want to be mindful of everyone's identities and recognizing there's multiple ones. So we tend to work with everyone. However, when we strategize this, how much effort we put into the dissemination of the information has a lot to do with who we're working with and how do we plan that information to trickle down. And at the end of the day, what is the community's desired outcomes and what's our desired outcome? What do we hope to gain from it from a population health strategy? So let me give you one example here before we dive into 3 others, and we're going to do case by case. But one that I didn't put here, but I think it's worth really emphasizing. We had flu vaccine drives, and I know it's kind of the conversation now with our own COVID drive, but we had flu vaccine drives a few years back, schools and then faith-based organizations. What was interesting at the schools, they had a close to 90% flu vaccine rates achieved, but it was really mandated, right? They were like, hey, to come to work here, you got to do this. Same thing with hospitals, mandating it, right? So I'm like, all right, if I got to work here, I get it. I work for this company, I have to get it done. And that's what drove it. At Southern Baptist, 2017, they achieved the same rates of vaccinations, flu vaccines, as these other 2 entities who mandated it. So how? How did you get a church to do just that? So it was fascinating when we go back and we review what we did with the congregation. We had these meetings over the summer and just asking, hey, tell us your community health needs. What was pretty consistent in the requests that kept coming up was this notion of jobs, of having a job, needing a job. And we're sitting here, we're like, well, we're doctors, you know, we're healthcare professionals. Maybe we'll bring HR and they'll have conversations. But then at some point you have to realize there's a strength that you can play that can align with those community health needs. So we actually presented to them a population health strategy talking about flu vaccines. Hey, flu vaccines have been shown to cause less days of work missed, less days of school missed. Well, why is that key to their identity for health being jobs? Well, if you don't miss a day of work, you don't miss a paycheck. If your kid doesn't miss a day of school, you don't have to take off. So we shared that information with them. That was our population health strategy, being the flu vaccine, and their community health interest being around jobs. And Bishop Hickman said, let's do it. He was on stage. He got jabbed in the arm on stage, a powerful message to his 300 congregants. Then we played that video for the 2nd worship service and that 3rd worship service, right? Because you can't keep jabbing him, poor guy, with needles. They got 90% of the community vaccinated. And what was fascinating with a very quick survey, 3 questions, more than 80% identified that they got it done, not only because it was there, it wasn't just an access point, but because Bishop Hickman got it done, right? That's the hierarchy of formality, the dissemination of information around people with an established homophily, and then transitivity was there, right? The next person told the next person to go, and so forth. You saw that happening in real time, a dissemination of information executed in the public fashion. That's key. So when you sit back and say, I want to end healthcare disparities, it's great, it's noble, it's a long road, because at the end of the day, what we really need is to establish a public health purpose that becomes an advocacy and ultimately legislation. Otherwise, you're still going to have a lot of proximal factors like education, transportation, housing, not feel accountable for the healthcare disparities that they'll cause, right? Because it's not hospitals, right? You think of the world's best hospitals here in the US, they're all planted in cities where there are healthcare disparities that are the largest seen in the world. Where hospitals are not designed to stop healthcare disparities. We're very much more designed to be reactive. What you need is community engagement to align with community health. That's key. From my standpoint, that's how we end healthcare disparities. And we see that more than ever in here with COVID, in regions where you had a high emphasis on community engagement with public health information for vaccines and face masking and so forth. You saw that regionally. So let me give you 3 examples. No, you know what? Let me give you 1 example. I'm going to try to pause. Laura, you know I could talk forever, so I'm going to try to stop in 2 minutes, but I'm going to give 1 example of something that we did and kind of how we thought about this when we implemented it. But this map always hits home with its life expectancy here in Baltimore City specifically. And you may realize, some regions are very red, and so that means their life expectancy on average is about 65, and others are much more green, 85. And that difference of 2 decades, I think what should settle in someone's mind is it's 2 decades, but these are places that aren't 2 miles apart, right? Like Curtis Bay to Roland Park, it's not that far. This isn't like going from, France to Senegal. This is, a few traffic lights and a little trip up 83 and you're there. And you've already gone through 2 lifespans. So let that sink in for a little bit, because in such a, Baltimore City isn't one of the biggest cities, but in such a small, a moderate sized city, you have such vast differences. So how do we end this? How do we end this? Let me go over 1 example. We'll do this one, and then we'll stop here and we'll take questions. Maybe you want to go over all the examples, that's fine. If I'm not getting any questions and you guys are like, but what I'm hoping, honestly, before we dive into this example, what I'm hoping is you guys are all sitting back more motivated, right? Because again, like I said in the beginning, when Laura asked me to give this talk, I've given plenty of health equity talks where people end it and just say, well, what can we do? Because you sit back being like, the world seems like a dire place. So much happening. What can I do? And health equities truly is something established from decades of a socio-historical context, whether intentional or unintentional, or with some level of ignorance and so forth. It's hard to move that needle, back to a more equitable strategy overnight. So people need to feel, everyone, even you all and others, need to feel some level of empowerment in the immediate sense. And that's why we try to emphasize community engagement and some basic principles to kind of go through your minds of saying, how do we make them even more effective? And again, it doesn't mean you shy away from other groups. You just recognize places with low homophily, without a formal hierarchy, you need to do a lot more legwork to get that messaging around. Versus others, not that much. Again, that flu vaccine, that was very effective. I mean, we went to several meetings, don't get me wrong. Once Bishop Hickman got the needle in his arm, that was enough, right? That was literally 5 seconds of work. Versus our housing units, when we go and work there, it is a lot of legwork to get people invested over time. So just keep, that's what we're trying to emphasize here. So let's go over this real quick. This is a quick example. We'll end, I promise you, at 10:15, and we'll leave plenty of time for Q&A. And we can talk about COVID as well and how we're doing community engagement around that. But the Lung Health Ambassador Program, to me, was a fascinating project that we launched after we met with a variety of science teachers in Baltimore City. So, we had a nice grant as lung groups and as a pulmonary group, and we said, well, we want to launch these cool science projects there. And, I'm on this team, and I said, well, can we just go talk to the schools first? Let's talk to the science teachers. Let's talk to the principals. What do they want? Community Engagement 101. What are their community health interests? So we met with a lot of the principals who just said, talk to the teachers. And we're like, great. Every teacher uniformly, it was fascinating. If you're ever concerned about the next generation, don't be. Because all these teachers said the same thing. They're like, all of them are kind of worried about disparities. And they may not have said those exact words, but they would say words like, a lot of the children are asking why more Black children have asthma versus the white kids in the classroom. Others will say other things like, why is my family, so much more obese than others, right? They will bring up these obvious insights identified that certain populations are impacted more than others. So clearly the underlying theme that these science teachers wanted to discuss was health disparities. Fine, so that's going to be our North Star. We're lung doctors, so we're going to aim at a lung health initiative. Now, with that said, we want to be the best thing you can do to a community is give them the ability to act on something. So what we actually wanted to focus on is tobacco. I know it's something that's been around since plaguing us for 100+ years, and it might not be the most attractive thing to focus on, even though it causes more preventable deaths in Baltimore and in Maryland than guns and opioids combined. And those get a lot of emphasis. Tobacco still is #1 cause of death, preventable death. So we wanted to focus on this. So, when you lay out this thought process, what is the population health strategy we wanted to achieve? Well, for the most part, actually, these kids are 6th to 12th graders. We didn't ask them, are you smoking or not? What we wanted to do with them is what we shared was, we talked about, all right, here's the lung anatomy. There's differences in lung health outcomes. Asthma is much more plagued in low socioeconomic areas and in areas with high minority populations. And every student kind of grasped that, right? And we said it, of course, I promise you, in a pedagogy that was appropriate for them to comprehend. And then we laid out this other map that showed those same areas are high in prevalence of retail stores that sell tobacco. And you remove that a little bit more and you realized, hey, high prevalence of active smoking. And so we discussed that, we walked them through this, that the majority of individuals, well over 95% of adult smokers began smoking before the age of 18. And if they can accomplish that, if the tobacco companies got them, then what usually happens is a permanent customer, right? A lot of it has to do with the neurobiological chemical properties of free-base nicotine. Won't bore you guys with that. So what we're trying to walk them through is to identify, like, if your goal is to end these disparities, end the most preventable cause of it. And so the students, what they got behind, we said, all right, are you motivated? They're like, yes. Like, all right, let's try to champion tobacco 21, meaning just raising the retail age of tobacco products from 18 to 21. This was going to be our public health advocacy, right? We got a population health strategy, meaning not smoking. We got the community health interest. They want to end lung-related disparities in their community. And can we achieve a public health outcome? That is the goal here. So what did we do? We got physicians and nurses to go into the classroom. Every physician and nurse began to have a conversation of who they were. The first lesson was all about getting to know each other. Why? That's homophily. Right? For a lot of these students, this is the first time they're seeing doctors and nurses outside of a clinic. They're freaked out. And I'll share with you an unintentional consequence. A year later, when we showed up, when we asked them who wants to be a doctor or nurse, almost everyone's hand went up. And Ms. Rodriguez pulls me aside after that and she goes, that only happened because you guys came last year and you're back again. You show that you care. So we established homophily, right? And then what we began to do is work with the teachers, right? After we left, the teachers were tasked with re-emphasizing that information, right? That hierarchy there. But we also got other teachers involved. We got the English teacher to help craft letters to Governor Hogan, and we got the drama teachers to teach them public speaking. So we took a few of these kids to Annapolis to give testimonies. This was powerful. And at the end of the day, we created some levels of transitivity by breaking them up into certain groups that keep passing on information, right? So group A, out of the 7th grade, they would focus on social media. Group B would focus on poster presentations, and group C would focus on a newsletter for the parents, right? So this peer-to-peer sharing of information, of transitivity, established through principles of homophily from us sharing information to them, and reinforced by a formal hierarchy in the organization of the school. So I say all this because I don't want to sit back and take credit that Tobacco 21 passed because of us. Probably didn't. Probably had other reasons. But these kids, these schools from Curtis Bay to Armistead, we had 600+ letters sent to Governor Hogan. We had a dozen students come to us at Annapolis. And at the end of the year, school year, when we graduated all of them, giving them certificates, it was one of the most well-celebrated, per the teachers, again, per the teachers, for me, it was amazing. But per the teachers, it was one of the best things they did. It united them throughout the entire year. That, to me, is a big impact of community engagement, right? You got the students to be energized, to be focused, certain principles clearly at play, transitivity, homophily, so we could disseminate information, reinforced by the hierarchy. It was powerful. And we got the end product, the public health outcome, because that was our goal. Our population health strategy really was, can we get tobacco 21? Meaning that should result in less smoking. So we got that public health outcome. Again, how much of a role did we play? hard to quantify, but do we get an energized bunch of young kids? You bet we did. And to me, this is what you can do. But you have to know who the community is. You have to recognize, all right, what's the information we want to share and impact? That's your population health thought. What's the community's health interest? The student shared with us. It was the lung-related disparities. All right, how do we establish homophily? And honestly, like for the most part, that script is easy in a sense of you just tell them who you are. Now, if you have other things that align with them, you should share that. And I shared it with them. Especially the schools in Highlandtown and Armstead. I was like, I grew up here and we established that. It was great. You're just becoming a human to them. And you teach these things to other people as well. Like, hey, go over your favorite animals, your favorite pets, establish some level of homophily. They want to see you as one of themselves. Because if you go in and be like, I'm Dr. G, I try to have fun with my name. I'm like, oh, it's a great DJ name. If I'm ever invited to bat mitzvahs, I'll share that. But what you really want to establish is that once everyone sees each other as one of the same, then that message begins to spread, can be reinforced by the hierarchy, and can continue to spread through transitivity. That's how community engagement can help end healthcare disparities. So this is key, because right off the bat, many people who talk about, and I'll stop sharing slides here. If you guys want me to go over the other examples, I'm happy to. But what I really just want to emphasize is healthcare disparities are here. They're not going away anytime soon. But it doesn't mean we sit back and we are just anchored by the gravity of their unethicalness, of their direness. We all can play a massive role, because these are health disparities, not medical disparities, meaning every human being who has a notion of health can begin to end them. And so from my standpoint, the last comment I'll make, and this is what we are trying to teach the next generation of doctors and nurses, honestly, what we're trying to do as hospitals need and warrant a revolution and an evolution is that if medicine is to be a public trust, it needs to engage with communities who already have the public's trust. So that's what's key for us, and that's what we hope to continue doing. And Laura and Susan, thank you so much for inviting me. Happy to take some comments and questions.